Good morning, everyone. Thank you for the opportunity to present, and thanks for being participating to this trauma telemedicine ground rounds. This is a case from really pre-COVID era. It's actually from my time when I did my trauma fellowship at Ryder. And the case is a 23-year-old male who presented with 2 stab wounds. Stab wound number 1 was to the box on the right side of the mid-sternum, approximately 5 centimeters long. And he had a second stab wound in the right forearm. This is how the stab wound number 1 looks like. The xiphoid process is probably here in this area. On primary survey, the patient's airway was protected. He was talking, functioning well. He had bilateral breath sounds. He was satting 99% on room air. He had 2 plus palpable peripheral pulses. He was a little tachycardic to 105. Blood pressure was 110/75. On D, his GCS was 15, neuro intact, equal pupils. And on exposure, you can see the stab wound number 1 in the box, and the right wrist was covered with gauze, but that was the second stab wound. So what are your immediate concerns with this type of patient, and what will be your initial management? Gary, if you wouldn't mind moderating for me. Thank you.
Yes, sir. Let's go to Portland. Dr. Kasim, your comments, please.
Good morning. It's 5 a.m. in Portland, so I'm glad to be with Alex this morning. So this is a young patient who comes into the trauma center in Miami with an obvious injury to the box. And you can very well ignore the second stab wound at this moment. He's not in extremis, he's stable, but that is just a false premise. He's going to crash very soon. I would be extremely concerned that he may have some vital organ or vital blood vessel injury, along with injury to the right pleural cavity. So I think you need to establish intravenous lines on the left side, not knowing where the trajectory is going to be, that he may have injured the right great blood vessels as well. So the first thing I would do, I would very quickly put my ultrasound probe onto his heart to see if he's got a rhythm, which he obviously has because you told us his pulse is intact, blood pressure is intact, and to see if he has any obvious pericardial effusion. And having done that, I would get a chest x-ray if he's still stable. And this should have been available for me even before the patient arrived, so that I can get the chest x-ray done in a few seconds. And I would definitely be concerned about a possible right pneumothorax, and I would go ahead and put a right chest tube in, irrespective of what the chest x-ray shows. So my main concern is going to be, has he injured his heart, causing pericardial effusion, or the trajectory is such that has he gone up into the thoracic as well as right subclavian area, where he could have injured one of those vessels. And also behind the box is the esophagus, and in front of the esophagus is trachea. I'm not concerned about the trachea at this moment because he does not display any signs of emphysema, etc. And I would be concerned with the esophagus as well. But my initial concern is going to be, does he have injury to the heart? Thank you.
Thank you very much, Dr. Kassim. Can we go to Columbia, Dr. Villaquere?
Thank you very much. I'd completely agree with Dr. Sim. One of the things that you should be obviously thinking about also is about the internal mammary artery. It's right there in front of that injury. So that would be one of the other concerns that would be there that I haven't heard mentioned. I think it's a bit lower. So the other way is thinking diaphragmatic injury or hilar injury of the lung on the right side. So those are other concerns that I would have about it. That would be my comments at this moment.
Thank you, sir. Sao Paulo, Dr. Tele, your comments, please.
Yes, I agree with the comments. I think this patient has an open thoracotomy in the right size. You can see the incision. You can see open at the upper the incision. So maybe I think I can ask if there's some air link for this incision. So it's very important to do because it's maybe an open pneumothorax. Sometimes in this injury, I believe it's need an X-ray at the moment, all TLS procedures protocol, but I think an X-ray. You can see a FAST, can see a pericardial FAST to see if there is some infusion in the pericardium. Maybe it may come a very quickly decision to have. In this position, you have problem because if you don't see it have active blending in this incision, is near the mammary artery in this position. So sometimes can be some blending through the incision and very, very big blending, so it can be treated quickly. So in this moment, I think these patients need an X-ray, maybe a ultrasound of the pericardium to see what's happened, and all protocol initial assessment of the TLS PCC airway is clear. I think there is no problem. I think the breath sounds maybe possible is normal. So have maybe can be crash maybe two venous accesses and go to image exams to the patient is stable at this moment. But I believe I want to know if there is some air link through the incision.
Thank you, Dr. Calais. Let's go to Boston, Dr. Mahoney.
Thank you. As all the previous colleagues have said, concerning for location, of course, ABCD, IV, get access. As previously stated, the FAST will be your friend here in that assess for a cardiac or great vessel injury given location. Also, that can be rotated up to the right chest to see if there's any pneumothorax. I see those as the two primary concerns based on location and within the box penetrating wound. So again, start resuscitation, plan for Boston massive transfusion, plan anticipated this guy's going to go to the operating room, but after a very quick primary, make sure we have an assessment of overall trauma burden. Then I would say, as I stated, the FAST, look for pericardial fluid as well as the pneumothorax, because although he's, as Dr. Kassim said, although his heart rate's okay now, he could rapidly decompensate, and that would be a concern. Thank you.
Thank you, Dr. Mahoney. Let's go to Toronto, Dr. Ali. Your comments, sir.
Yes, I presume he has the left side, and I would put an occlusive dressing on that wound, and I understand that was inserted, Dr. Kassim, is that right? And I'm waiting for him to stabilize at some point. If he stabilized enough, I would go on to get a CT of his thorax to see if there's anything that's visible there relating to his or anything like that, but that's only after he's been stable. And of course,
Dr. Ali?
yes.
I'm sorry. Were you finished, sir? I'm sorry, you're breaking up.
Oh, yes. Occlusive dressing, chest X-ray, and chest tube, Foley catheter, and getting him ready if he's stabilized to get a seize like hemodynamically. So that's my comments for the time.
Okay. Thank you very much, Dr. Riley. Let's go to Bangkok. Dr. Super.
I agree with all the previous comments, and for the management, just give him some fluid, oxygen, get the chest X-ray and fast exam of the heart and abdomen, and prepare for an operating room just in case he gets worse. Thank you.
Thank you, Dr. Super. All right, Dr. Untrack, your comments, please.
Yes, I couldn't tell where that second stab wound was, but I take it that it's irrelevant now. It seemed like maybe it was in the left chest, but I'm not sure. But assuming that that's not relevant, I agree with pretty much all of the comments. I would get an immediate ultrasound to look at the pericardium and also both chest walls and pleural cavities. Especially if he remains tachycardic after receiving some fluids, that suggests that he's lost a significant amount of blood, probably on the right side. And in addition to the heart and other mediastinal structures, I'd worry about the pulmonary hilum being injured on the right side as the source of blood loss. So, and I think if he's persistently tachycardic, it might be a little bit risky to take him to CT at this point. So I would try to determine how much he's bleeding where, and then plan an operation based on those findings.
The second stab wound was on the right wrist, Dr. Ontrack, and it's in this picture here.
Oh, just the right wrist. Oh, okay, I thought there were two to the box. Okay, very good. Okay, so it's not relevant.
Thank you, Dr. Untrack. Do we have any other comments before we return to our presenter? Okay, back to you, Dr.
Yeah, I don't like this position of this stab wound. So again, and this stab wound in the box and this area, like a fast, can be false negative if there's a injury that perforated pericardium and it's bleeding through the chest or whatever, and also maybe just tamponade. So this is the kind of injury that just a fast can be very tricky and give a lot of pitfalls. So I'm very concerned about this injury, Alex.
Yeah.
This is Horacio Hoffman in Boston. I apologize for connecting, and I had a problem connecting. If I can make a comment, if patient like this presents to the emergency department, he will get, first of all, we do here something that we call an extended primary. We very quickly look for other holes, and after that get a chest X-ray and a fast that we will do with a subxipho window most likely. And based on those two findings, most likely than not, the patient will go to the operating room. If this wound is deep enough, the right mammary artery is probably transected. As Dr. Untras mentioned, the pulmonary hilum might be injured, the heart can be injured. There are too many things that can go wrong with this patient. Very unlikely I would travel with this patient to the scanner. And I definitely would not do a local wound exploration in the emergency department.
Yeah, that's exactly my comment. With this kind of injury, I don't know if you can say the patient stable enough just being 10 minutes in the trauma base. So there's a kind of patient that can just trick you and become really hypotensive or in the CT scanner. I will probably send him to the OR to explore at least a pericardial window initially. So I'll be very concerned about this patient.
Thanks for all the comments. Go ahead, back to you, Dr. Alex.
Thank you for all the comments. To answer Dr. Colette's question, there was no air leaking out from that wound that we were able to appreciate. What we did, we got a chest X-ray that showed no obvious pneumothorax. We did a fast that showed no free fluid. We did start peripheral IVs, then we started IV fluids. The location here on the X-ray, kind of where the stab wound was, we didn't appreciate any pneumothorax. And for the ultrasound, this is more like a parasternal view because he was tender over the xiphoid. So the subxiphoid view was not really yielding much. We did the parasternal view. We were not able to see any fluid around the heart, and we can see the pericardium. We proceeded with the rest of the examination. No other, nothing significant on the ample history. There was some bleeding from the wound edges of the wound at the right mid-sternum, and he had tenderness of the xiphoid process, as I mentioned, and the right forearm wound was not bleeding at all. So how I would like to proceed now, the patient is hemodynamically stable. If you can please comment on that, proceed to more imaging or do something else.
Thank you, Dr. Alex. Let's go to Bangkok. Dr. Supa.
I think at this point, it's safe enough to send the patient to CTA of the chest to look for a cardiac and great vessel injury or other bleeding lesion in the chest like a non-mammary artery, because you're gonna see extravasation if there is bleeding from that vessel. And to also check in the abdomen for this patient, because the trajectory could have gone down to the belly. So CT of the chest and the abdomen. Thank you.
Thank you, Dr. Supa. Iraq, Dr. Untrak, your comments, please.
Yeah, so hemodynamically stable, I suppose that means that after intravenous fluids, he was no longer tachycardic, and then with the chest x-ray showing no signs of bleeding whatsoever, then I agree with Dr. Supa. I would do a CT with intravenous and oral contrast to evaluate for potential esophageal injuries and also any vascular injury in the mediastinum or nearby.
Thank you, Dr. Untrak. Toronto, Dr. Ali, your comments, please. Go ahead, Dr. Ali. Okay.
I agree with everything that's been said. I would put a test tube in this patient because it's presumably that patient on the right side. But I agree, if he's stable enough, I'll put him, get a CT scan to look at the mediastinum, the cardiac silhouette, and so on.
Thank you, Dr. Ali.
There's nothing more at this point.
Okay, great. Thank you, sir. Dr. Mahoney, did you have your hand up, sir?
Yes, if I could just follow up on something Dr. Untrak said, is that what was his responsiveness to the fluid? Often our residents describe patients as hemodynamically stable, but stable tachy. Is his heart rate still 1-teens? I think it was 105 initially. What was his responsiveness to the fluid? Or is he hemodynamically normal, which would be much more reassuring? So if he's still tachy, 105, 110, may continue to watch him in the trauma bay and repeat the fast to see if anything's developed. If he is normalizing, improving in his fluid, then taking him to the CAT scan for the CTA to assess the vasculature. You know, we talked about, several people have mentioned the mammary vessels, also looking for, you know, other things like aerodigestive, esophageal, or some more subtle vascular injuries. So can you expand upon that, sir?
Yes, his heart rate came down to low 90s and his blood pressure remained, I think it was 110/75.
Thank you.
Thank you, Dr. Mahoney. Sao Paulo, Dr. Calais, your comments, please.
Yes, in this situation, if I have angio CT, the patient is hemodynamically stable, I prefer to have a angio CT. If I don't have a CT at this moment for any reason, I think these patients need to go IOR and exploration of the wound. We'll do the anesthesia, can see, and then you can treat if it's possible. Then the wound, probably I make a pericardial window to confirm the ultrasound findings.
Thank you, Dr. Calais. Let's go to Colombia. Dr. Villaquirin.
Yes, I agree with the doctors above there. Yeah, and the only thing I wouldn't do would explore that wound still until I get the CT scan, and I would explore it only in theater with all the precautions, because I'm still very worried about everything. Thank you.
Thank you, sir. Boston, Dr. Hoyman, your comments, sir.
No, I don't have anything else to add to whatever was said. The patient is stable, should get the CT scan. Thank you.
Thank you, sir. Ryder, Dr. Marcos. Dr. Martos may be busy.
Again, if the patient really stable, can be in the CAT scan, the patient will go there. If you don't have the CAT scan close to your trauma ward, etc., I would go to operating room, the pericardial windows at least.
All right, thank you very much. Dr. Nemais had mentioned earlier that he may be driving. Are you in a position to comment, sir, Dr. Nemais?
Not really. I'm in traffic. I'd rather not.
Okay, very good. Any more comments before we return to our presenter?
Dr. Gary. Gary, can I say something?
Absolutely, Dr. Kassim.
So this is the kind of stuff Dr. Trunke taught me not to send the patient to the CT. He said, beware of the boogeyman. Any injury in the box, you have to be extremely careful before you send the patient to the CT, because that's where the patient could die. So before I send this patient to the CT, because of the location, and I'm one of those guys who is extremely suspicious of things, and ultrasound being negative, I don't really believe that. So I think I would take the patient to the OR, where I would do a subxiphoid pericardial window and make sure that I'm not seeing anything that I don't want to see. And then I have the luxury of sending the patient to the CT because he will not crash.
All right. Thank you very much, Dr. Kassim. Back to you, Dr. Alex.
Yes, thanks everyone. These were all great comments and input. So these are the questions that we went over with the whole trauma team, from like students to residents. We stayed in the trauma bay, observed them a little bit, repeated the fast. Obviously, not we didn't close the wounds. Workup, we discussed about repeating chest X-ray and fast. We were concerned that he was tender, the xiphoid process area, and we were concerned about the trajectory and involving the upper portion of the abdomen and maybe even liver. So his blood pressure after fluid was 120/80, heart rate in the mid 90s. We got labs back, so we watched him over there a few minutes. Hemoglobin 13, creat was 40. He did have a base deficit of -2. So we covered with the gauze and taped the wounds, and we took him for a CT angio of the chest. And we were gonna get the upper abdomen on those with the CT of the chest. And the arrow top shows where the defect in the soft tissue is. The arrow on the right side of the screen starts showing air in the pericardium. I can see now why basically an X-ray, AP X-ray, the way it's shot is not really gonna show very well the pneumopericardium on X-ray, even though radiologists started going back and saying, yeah, there was maybe a little bit of pneumopericardium. And now we also see a little bit of blood layering right anteriorly to the heart. Looking at the right lung, there was no pneumothorax, and we did not put a chest tube in the trauma bay. And I don't know if that would have changed things. However, this is another image of the CT of the chest, just localized pneumopericardium, and then the trajectory kind of explaining his tenderness over the xiphoid region with the air kind of tracking in the area. The liver did not appear to have any lacerations. And again, a little bit more air tracking with, intact skin here up top. So the trajectory was definitely inferior. And now we're coming back from the CT scan, and his pressure is 80/65. And what would you do next? And going to the operating room, how would you proceed with sternotomy or left antral thoracotomy, or any other options? If you can please comment. Thank you.
Sao Paulo, Dr. Calais, your comments, please.
In these situations, have these patients maybe come unstable, so the patients go to OR. I think if I have equipments to do, I do a sternotomy in this case. If I don't have equipments for do a sternotomy, sometimes I don't have this one in the hospital, I go to left thoracotomy in this situation. So, but I believe the sternotomy is the incision of the choice. I can treat by this incision.
Thank you, Dr. Calais. Columbia, Dr. Villaquarian, your comment, sir?
Yes, no, immediate to theater, and we have in our theater the ability to do a sternotomy, so we would do a sternotomy. That would be our first way in. Thank you.
Thank you, sir. Boston, Dr. Hoyman, your comment, sir?
A little bit backtracking here. The pericardial tamponade, there's always described like 3 stages. Stage 1, the cardiac output is maintained and the patient is doing fine. Stage 2, the cardiac output start dropping, but other compensatory mechanisms are in place. And one of them is to increase the CVP. So this is despite the recommendations of not giving volume to patients with penetrating torso injuries that's been published in the New England Journal of Medicine a few years ago. This is a patient that I will give volume if the patient becomes hypotensive, because the only way to overcome the increase in intrapericardial pressure is to increase the central venous pressure, the pressure inside the right ventricle. And I will go, if I can, to the operating room. If the patient is too unstable, obviously we'll get the left anterolateral thoracotomy in the emergency department. But if not, I will go to the operating room. A few recommendations in the operating room: the arms need to be tucked in both sides. We are very used at doing general surgery cases that the arms are kept on the side so anesthesia get access. But the arms, in order to do this, is really simplifies everything. If the arms are tucked to the sides of the body, I will discuss the case with anesthesia. I will prep the chest before induction, because despite induction, sometimes where they say a tummy date is not so, doesn't affect the hemodynamics so much. It does. These patients many times are borderline. The moment they get induction, they crash. And I had to have everything ready to do a median sternotomy very quickly if the patient crashed during induction. Median sternotomy give a much, in my opinion, a better approach. It's also less postoperative pain. The recovery is faster. The left anterolateral thoracotomy, in my personal experience, I know what is being written, that you can repair like 95% of the injuries to the heart. I found it very, very limited. Maybe I'm a bad surgeon. I cannot get anything done to a left lateral thoracotomy. I always end up doing a clamshell incision, which really gives you a very good access to the chest, except that the recovery is a little bit more, it's hard for the patient when you do a clamshell incision. Those will be my options. If I am in the OR and by any case the patient that things get delayed, I might try to decompress through a subxiphoid window, which I doubt. But those will be my options for this patient. Thank you.
Thank you, Dr. Hoyman. Dr. Untrack, your comments, please.
Yes. So in retrospect, looking at the CAT scan, it probably would have been a good idea to take, based on what Dr. Qasim said, to take this patient directly to the operating room. And then also, I think Dr. Qasim's approach in this case might have been a little bit smoother, because you would have seen the blood and then proceeded immediately to the median sternotomy and taken care of the problem. So, but I think based on the situation you have now, I agree with what everyone else said. Back to the operating room, median sternotomy, and deal with it as expeditiously as possible.
Thank you, Dr. Untrack. Bangkok, Dr. Super, your comments, sir?
I agree with median sternotomy at this point. Thank you.
Thank you, Dr. Super. Portland, Dr. Qasim, your comments, please.
So we have a patient now who has air around the pericardium, and also the radiologist probably is wide awake now, and he told us that there is layering as well, which he could have told us before. It would have helped us a lot. Anyhow, be as it may. So the question now is, where did the air come from? Did he suck the air in, or is it something else that we are overlooking? Air per se is not going to kill him, but the layering obviously is blood. So did he injure one of the chambers of the heart? If so, most likely from the stab wound itself, I would be very concerned that he probably nicked his right atrium. So, I would bet my money on cardiac injury, and hence he should be in the operating room. And median sternotomy is the right approach for this type of injury, because you'll be looking at it directly from the trajectory as well as the site of the stab wound. I'm suspicious he's nicked his right atrium somewhere. Thank you.
Thank you, sir. Toronto, Dr. Ali, your comments, please. Go ahead, Dr. Ali. Okay, we'll come back. Boston, Dr. Mahoney.
I agree. He needs to be taken to the OR, as everybody has said, and
I'm sorry, Dr. Ali, we lost you, sir. If it's okay, we'll come back to you on the next round. Apologize for that. Boston, Dr. Mahoney.
As previous colleague said, I think it needs to go to the operating room. I do the median sternotomy. That would give access to everything that my colleague has said. Also, it's extensible based on the trajectory that showed it seems to travel from cranial to caudal. So that would be extensible to the abdomen should I need that. Thank you.
Thank you very much, sir. Don't think we missed anyone. We have Dr. Martos.
Yeah.
Yes, sir. Go ahead.
Yes, Gary. This is a good discussion. You know, there's some concepts that you discuss here. First, I had an old professor also, Dr. Cassin, would say that the only patient in trauma that you can guarantee that he's hemodynamic stable is the patient that's in cardiac arrest, the patient's dead. Otherwise, the hemodynamic can change at any minute, right? So I would say that at Ryder, you have a CAT scan that's just like a 50 feet away from the trauma bay. The operating room is always available, another 50 feet away from us. It's very close. But we had discussion before, Dr. Namai, so maybe he can comment later. So when you say, oh, the patient is stable, let's do a quick CAT scan. A CAT scan is never quick. Once you decide to go to patient CAT scan and go there and come back, it's a half an hour process, right? So first I would say, if your hospital doesn't have the CAT scan close by, forget it, right? So it's really risky to do that. So, and then you have some papers in the last few years from Colombia saying, oh, you can send some patient like a little bit hypotensive to CAT scan and monitor the patient. Some people just say no. As Ryder, if I do this, I need to justify next day to Dr. Namaya's. And if your patient became hypotensive, it's kind of injured the CAT scan, I need to justify the M&M to the whole department. So that's kind of tricky. I'll say the patients that are borderline or are stable, you think can go to CAT scan, you need to go to blood available, 2 peripherals IVs, large bone, etc. Sometimes you place an A-line, most like patients like with blunt trauma, like pelvic fractures, etc., etc. But this kind of wound, I would say I would go to the OR, like I said, pericardial wound initially, and then in this situation, sternotomy. I know that in South America, we used to do sternotomy a lot, most likely because usually you don't have in the trauma trays like everything to do with sternotomy, and Dr. Collet said that in multiple hospitals you just don't have the tools. But I think that need to, it's mandatory in this case, wound in the box to start with sternotomy. But you still can have a lot of pitfall, a lot of surprise during in the OR, and I'm pretty sure that Alex is going to show you some good surgical injuries here. I don't know, Dr. Amais, you want to make a comment, because this is one of his points about sending patient to CAT scan with injuries that can become unstable or patient can shock like during the CAT scan.
Good. Do we have no other comments? We'll return to Dr. Alex. Go ahead, Dr. Alex.
Thank you. So great, again, a great round of comments. We basically, so as Dr. Marta said, that rather you get out of the trauma bay, you take a right, you're straight in the operating room, you take a left, you get to the CT scanner. Here at Jefferson, we actually have a trauma OR right next to the trauma bays. So, and the CT scanner is a little further down. So probably, you know, a trip there with the patient, like, you know, instead of like rolling all the way down the hallways to go to the CT scanner. In my previous job in an underserved area, the OR is further away from the CT scanner, and with this patient I would have, you know, rolled straight to the operating room. And I think you know, to quote Dr. Hoyman was saying, this patient, you know, started with basically you know, decompensated cardiac output in stage 2 of the tamponade. So what we did, we gave him a 500 cc bolus, we activated MTP, and we rolled to the operating room with a blood pressure of 110/70. We placed the patient supine on the operating room table. He was actually awake and prepped and draped. He was stable during induction and intubation with a blood pressure of 105 and 62, over 62. You know, we also had the information from the CT scan that basically nothing posterior or posterior to the heart, like things that were enumerated, including lung hilum and all that, did not appear to be injured. So that was a useful information that we had. And we decided to perform a subxiphoid pericardial window. We noted that the xiphoid process was partially transected by the stab wound, which basically opened the pericardium. There was air and blood that was released. There was not a lot. It was what you see on that sponge on the right side of the chest. The patient's blood pressure now is 130/70, and these are some pictures from the operating room. The arrows are pointing to the 2 Alice clamps that are holding the pericardium, which was open. The Army Navy here is where the xiphoid was transected, and it was bleeding from this area of the xiphoid that was transected. This is a better view. We can see the heart pink right in the middle where the green arrow is pointing towards. So what would you do next? Sternotomy or no sternotomy? This is the question. There has been a couple of cases discussed here on this conference, and with this information, with this amount of blood, patient blood pressure recovering, do we proceed with sternotomy or not?
We go to Columbia, Dr. Villaquirin.
Well, having trained here, I've had lots of pericardial windows which were 2 drops. If it's positive, and he gets a sternotomy. And thinking about where the injury is, probably the right side of the heart, low pressure, you've increased the amount of fluids and corrected his hemodynamics. But I still think he has and I have to make sure that he doesn't have a right-sided lesion. So the answer to your question, yes, sternotomy. Thank you.
Thank you, sir. Portland, Dr. Kasim, your comments, please.
In box injuries, I don't like to do keyhole surgery. You know, either you have it or you don't have it. You know, once you're already there, you saw blood, open it up so that you sleep better.
Thank you, Dr. Kasim. Bangkok, Dr. Super, your comments, please.
In this situation, I prefer to do a full medial sternotomy to explore the heart thoroughly and repair whatever I find. Although there are some evidence since that said that you may observe this type of patient, positive pericardial window, but no active bleeding, and the patient becomes hemodynamic stable after the drainage. Some say that you may put the drain in and observe, but I prefer to explore the heart via median sternotomy. Thank you.
Thank you, Dr. Supa. Let's go to Toronto. Dr. Ali?
Well, this patient hypotension, and but he was hypotensive, and when the pericardium was opened, it seems the story goes that his blood pressure improved as well. But you're there already. I think you need to make sure there isn't an injury by exploring, allowing you to explore by doing your the heart and the chambers to make sure there isn't a bleeding. That will go ahead and close this patient because there any crashes again. So I want to make sure while I'm there that I have a good look, and that's what I would do.
Thank you, Dr. Ali. All right, Dr. Untrack, your comments, sir.
Yes, I agree with what everyone said. You know, in this situation, it's much better to do a sternotomy and find that, okay, if you didn't do it, you would have been okay, than not to do it, and then worry all night and, you know, not knowing if it's going to crash overnight, and I just wouldn't be able to sleep. I think it's really this much safer thing to do, and much better judgment to go ahead and do a sternotomy in this case.
Thank you for your comments, sir. Boston, Dr. Hoyman, your comments, please.
Yeah, I will do the sternotomy too. I know that there are papers. There was one big series from South Africa where they put the drain and appeared to be okay, but I also know there were some methodological issues with that paper, some ethical issues, how the patient selection was made. So I agree with all the previous speakers. I really feel that if you are there, just do a median sternotomy and take a look. Thank you.
Thank you, sir. Sao Paulo, Dr. Tele, your comments, please.
I agree with the comments that it's more safe to make a sternotomy and try to see what's happening in the pericardium and the heart. But in this situation, sometimes you can put a drain. The patient is stable. There is no bleeding comes through the pericardial window. You can see, you can put a drain and observe. Sometimes the bleeding comes through the injuries of the chest wall and as the air go to the pericardium, this blood can go to the pericardium too. If there is no heart injury. But if you don't have some things to observe and the equipment is too big to go quickly to go to the theater again. So if the patients start blending, so you can have to make safety and make a sternotomy. If you don't, you have all the tissues you can put in. The patient is stable. There is very little blending on the pericardium, so you can put a drain and observe.
Thank you, Dr. Clay. Writer, Dr. Schneidman, your comments, please.
Hi, yeah, I'm not a writer anymore. I'm at Westchester Medical Center in New York.
Oh, okay. Sorry about that.
That's okay. But Alex, great case. I think for any residents or fellows on the line, I think key points here is, you know, if you get the X-ray, which this patient didn't have, but if you have a hemothorax, your FAST is unreliable. The other thing that can make a FAST unreliable is air. So having pneumopericardium can make it very difficult to get a good view of the heart. Once you got your CAT scan here and you see air and layering fluid, you know that there's some sort of injury happening. I think in this case, you know, you could probably just go straight to the sternotomy because the window is usually, it's therapeutic, but it's more so diagnostic to know what's going on there. But we already have our answer from the CAT scan. The other thing is, you know, he was initially hypotensive with 80/50. If he remained hypotensive, I think the right incision would have been a thoracotomy. But thankfully, after receiving some volume, he responded. So I think going forward with a sternotomy is probably the best option. And somebody mentioned the South African study. I think you have to be very careful to apply that to your patient, because in that South African study, patients were admitted to the ICU for 24 hours. If during those 24 hours they became unstable, they had a sternotomy. If they were stable for 24 hours, then they got the window and the drain irrigation thing. So you have to be very careful. You're getting these patients straight out of the street, not out of 24-hour window of observation.
Thank you very much for your comments, Dr. Schneidman. Dr. Martos, Ryder, your comments, please.
Yeah, so this is an example. Okay, the CAT scan helped us with some diagnosis, but then you have, so with the CAT scan, should you go to pericardial windows or go straight to sternotomy? So that's a good question. Without the CAT scan, I would go to pericardial windows, like I said before, and then possibly sternotomy. I treated, and we had like 3 months ago, 2 cases back-to-back, one for me, another for Dr. Ruiz, with penetrating injuries, positive window, positive fast, went to the OR, did the pericardial window, and this patient stable, and then just had a little bit of blood, and then nothing else happening, and just left a drain. So probably patient was bleeding for pericardial and nothing else. But to do that, you need to be in a location where you can monitor the patient, follow the patient ICU. If you're not in this kind of situation, you need to do the right board answer, you could say, is to do a sternotomy. So you need to be very careful when you decide to do something out of the box from this kind of patient. If you can follow the patient, I know sometimes it happens 4 a.m. your call, you're going to go home next day. Who is going to follow this patient? So if you want to be in the safest side, you need to do a sternotomy. Anything else, you need to be sure that you can close monitor this patient. In this situation, I would open. I have some questions. There's anybody from Hamad in Qatar here, Dr. Hamad Ajaj is here. If there's somebody from Qatar, because they have hybrid rooms, they have everything that have. I just like to know how they would treat this patient over there also. And anybody from Qatar? I saw Dr. Ajaj here. Can you make a comment, sir?
Yeah, Dr. Marshall, I don't know if he's still with us.
Yes.
Oh, okay,
Good morning.
Good morning, sir.
Thank you for inviting me to speak about. Actually, we are here in Qatar in Trauma Bay. The CT scan, it's about 50 meters from Trauma Bay. I think with those cases, usually we go to CT scan. And after CT scan and finding that like this, I think sure we will go for a sternotomy. Like what while the patient's stable, reasonably stable, I mean, and we are near the CT scan, and the OR, it is a little bit away from the Trauma Bay, so we'll go to a CT scan. Thank you.
Thank you, sir. Any additional comments before we return to our presentation? Okay, back to you, Dr.
One quick comment.
Yes, go ahead, please.
One other argument, I think Dr. Untrak mentioned this before briefly. One more argument to do a sternotomy in these cases is that if the injury is to the right side of the heart, it's a low pressure system. It's very easy to form a clot and the bleeding stops. You aspirate, bleeding stops. When the patient wakes up and start coughing and start doing Valsalva and increase the pressure in the right side of the heart, the bleeding can restart and you are going back to square one. So that would be my argument for another part of my argument to go for the median sternotomy. Thank you.
Thank you, Dr. Libby. Okay, back to you, Dr. Alex.
Okay, thank you for the comments. So what we ended up doing was pericardial drain with irrigation. We used 250 cc's of saline. There was really no more bleeding. We actually did intraoperative TEE. Anesthesia was there and look at the chambers of the heart. There's no wall motion abnormality, nothing abnormal really whatsoever. Let's see if the video can play. So you'll see on the left side, basically the Alice clamps on the pericardium, the syringe on the resident's hand on the left hand with the drain that's about to go in. Other than what's on that gauze, there was no more bleeding at all. And then on the right side of the screen, the TE really kind of giving a good view of the heart, and with the suction, you don't see anything coming out, but as soon as it was irrigated, it was suction out, it was all clear coming into the suction. So basically, what we ended up doing was not to proceed with sternotomy. We left the pericardial drain, we put a right chest tube, and we closed the wound. On the left side of the screen is basically how we proceeded with the pericardial, subxiphoid pericardial window, kind of extended down here from his wound. On the right side, the drain and the closure that we did after. He was extubated in PACU. His right chest tube came out rather quickly in post-op day 1, no air leak, not draining much, x-ray looked good. Pericardial drain was removed in day 3 with minimal fluid. He went home on day 5. He basically came in clinic to have the staples removed, which actually approximated his tattoo very well. And we did do a repeat echocardiogram. This was a paper that came before I started my fellowship at Ryder, and was kind of, I still consider myself not, seasoned, and definitely depending on the location and which hospital you're at, and I've been in level 1 trauma center, I've been in underserved areas. When I read this paper, I was definitely not gonna do this, and I would just go with sternotomy, and that's the board answer for residents who are listening and participating. I'm not gonna, in the interest of time, I'm not gonna go over this paper. This is the one that was mentioned by the participants from South Africa, and by Dr. Sneedman, who explained very well the paper and the findings. So basically, for me, considerations here, moving forward, right, for stab wound to the box. What should we consider, with regards to, doing treatment with just, pericardial window and just leaving a drain? Who should get that? What I think we should consider is, is it blunt mechanism versus penetrating mechanism? How's the patient doing hemodynamically? And then, is it pneumopericardium or hemopericardium? And I think probably looking forward, we should, tease out these patients. Pneumopericardium versus hemopericardium. We saw patients with blunt trauma where the air tracked around the vessels and ended up in the pericardium. That was a couple of months ago, a paper presented that was treated with just drain placement and not sternotomy. And then Dr. Supa presented a case where he wished he did the sternotomy, and he didn't do it, and then he did it a week after. So those are probably things to consider where you do just subxiphoid pericardial window, drain or no drain, plus or minus sternotomy. I think also if you're able to have a CT angiogram of the chest before, if you have availability to do a TE in the operating room, and then if you decide to go with the minimally invasive option for let's say pneumopericardium and a little bit of hemopericardium, like in this case, definitely think of a follow-up with week repeat echocardiogram, so you don't miss anything that's slowly developing. So what was it in this case that caused all this? Was it a right pneumothorax that emptied into the pericardium? If I would have maybe done an EFAST, maybe that would have been a way to see it, because the x-ray didn't help, and then put the right chest tube, and then the CT scan maybe would have been with different images. Or was this an open chest wound that basically sucked air inside, and the fact that we covered it with an occlusive dressing basically led to this. So in any case, even Rocky is wearing a mask here in Philly, so wear your mask. Be safe. Thank you. And if you have any final comments.
Let's go to Boston. Dr. Oyman, for your final comments, please.
I don't have anything except to congratulate the presenters for a very well-managed case. The review of the literature was right on the spot, and thank you very much.
Thank you, Dr. Oyman. Sao Paulo, Dr. Calais, your final comments, sir.
Thank you for the presentation, to share your case. It's a very nice case. Thank you.
Thank you, Dr. Calais. Columbia, Dr. Villaquirin, your final comments, please.
Yes, thank you very much. Well-presented case. I still, unfortunately, have had, when the experience gets to you and bites you, you usually prefer to do the sternotomy. And I agree with that. There are papers coming out and telling us that in some cases, if you have the way to monitor these patients, you can get away with it sometimes. But I still think that it's a risky business. And thank you very much for all the comments and participation.
Gary, may I?
Yes, sir, please.
So I think I understand all the trepidation about this, but you know, these are the same things we thought back when we, you know, started doing non-operative management of spleens, and it's the slow, you know, unavoidable progress that's happening, and case selection is going to be very important. But this will help some people. In that prospective randomized trial that Dr. Schneider mentioned, the only death was in the group that got the sternotomy because they died of an unrecognized postoperative iatrogenic IMA injury. So there's a balance. And overall, congratulations, Alex. It's a great case, and these lessons have to be expanded upon, and these protocols will evolve.
Thank you, Dr. Nemayes. Bangkok, Dr. Super, your final comments?
Thank you very much, Dr. Alex, for presenting this case. And from the discussions, I've learned a lot about managing this type of patient. And I'm very happy to see Dr. Nemayes today too. Drive safely, Dr. Nemayes.
Thank you, Dr. Super. Toronto, Dr. Ali, your final comments.
Okay, just one comment. I remarked initially in this case that I would have put a chest in because I didn't think the chest x-ray in the supine position would have been reassuring that there wasn't. And of course, the chest x-ray missed the pneumopericardium as well. Whether this became more extensive later on, I don't know. But that's what I would have done. Thanks.
Thank you, sir. Oh, Iraq, Dr. Untrak, your final comments, please.
Yes, very good case, well presented, learned a lot about the options. And I would say that, you know, the choice of sternotomy versus the lesser invasive option depends on the level of experience for the operating surgeon. A dedicated trauma surgeon who's got tons of experience with this, I think, has the moral authority to be a little bit bold. And, you know, as time goes by, it might become the standard of care for everyone, for all surgeons. And so I think that's the decision to make. And it's good to see a well thought out plan based on current literature that worked out well. I think that's a very good demonstration of expertise here.
Thank you very much, Dr. Untrak. Portland, Dr. Kasim, your final comments.
Thanks, Alex. I'm glad I got up at 5 to listen to this wonderful presentation. My take on this is once burned, twice shy. If you go through something like this and you miss it, and then you pay a big price for that. And in a big trauma center like in Ryder or even in Philadelphia, I think you have the luxury of doing something like this because you have tons of people to salvage when something goes wrong. But for everyday surgeon, I think it would be very risky. And again, Dr. Untrak is correct. I think it all depends on how much experience you have in taking care of patients like this and how comfortable you are to get to the heart quickly should problem arise. But for a Joe Blow surgeon, I think it is very risky. Thank you.
Thank you, Dr. Kasim. Dr. Ajaj, your final comments, please. Let's go to Dr. Martos then. Do we have anybody before Dr. Martos makes the closing comments?
Yeah, sorry. Thank you. Actually, it's very good case, very good. I learned a lot from it. I think it is well managed, and still there is way to do like conservative. I mean, little bit conserve incision and manipulation in surgical approach, but still for learning purpose, still sternotomy is the best way. Very good managed, and thank you very much.
Thank you very much, sir.
If I can make a quick
please go ahead.
Question to the group, and I hope I don't get banned from this meeting from asking this question. Some crazy idea that came to me when I was watching the pictures. What about putting a scope through the tiny hole? Ideally, it would be a flexible scope like the kaleidoscope, but taking a look at the heart and make sure that there is no injury, because an injury to the heart here has to be anteriorly, and it's difficult to see through the subxiphoid window, but maybe that might be the future, just to put the scope inside, take a look, and there's no injury to the heart, you feel comfortable leaving the drain and coming out. Just kind of like a crazy idea, if anybody will do anything like that.
Could I add to that? Gary, may I just add to that?
Yes, please.
Briefly?
Please.
Yes, that was my thought as an option during the discussion, especially a thoracoscope or a side viewing, rigid laparoscope. You get a very, very good view, and you'd be able to look at the entire pericardium and the surface of the heart. But it's non-standard. I think we've had other cases where, was it the one case that Dr. Super presented where he wished that he would have opened the pericardium? I think the approach was a little bit non-standard, and that was the only thing that kept me from bringing that up, because I think that it was it was something that would not be done routinely. It would require evaluation by more expert surgeons in trauma than I. And but I did have that thought, and I think it's certainly a reasonable question to raise as an option to at least talk about outside the operating room.
Any other comments in that regard?
No, I'd say, Dr. Hodgman, that this would be a case report, and that's exactly what Dr. Myers was saying, that maybe this is going to be the future. So slowly, the new techniques, new procedures, new approaches are coming. Of course, you need to have common sense. You need to be in a center that can manage and can clearly, closely monitor the patient. But this would be maybe in 5 years, it's going to be a good approach, a standard approach. Maybe in 10 years, it's going to be, we're going to be asking ourselves, how did we do before this kind of procedures, But again, it's coming, and I pretty sure that some places like your hospital could be able to manage that, and maybe we'll be doing that. You're having these meetings for 10 years right now, and every meeting you learn something with each other. Every meeting have a good case, and again, that's why you're continuing doing this. It's amazing how from different parts of the world, the globe, you have people doing things, sometimes different resource, sometimes with more resource, sometimes with limited resource, but at the end, you do the best for our patients, and you show each other different ways to manage the same situation. I'm really happy with this. I would say the Pan American Trauma Society has a strong goals for the next year. And one of the goals is going to be to make this meeting even stronger. and to do collaboration, to do multi-center trials or write papers together. So, and again, for 10 years, this group has been together, and I just see this group getting stronger and keep going on. Okay, my friends, good to see everybody. I wish everybody safe. I know COVID is going up everywhere, so please stay safe. Keep doing a strong work. See you all. Yeah, good job, super. And see you all next week. Thank you very much.
Thank you.
Guys.